Coming up next, Sitting at 30 takes you downtown for the weekly luncheon meeting of the City Club of Portland. Live weekly coverage of City Club is produced through the facilities of Portland Cable Access. Now we join the City Club for this week's program.
Good afternoon. I'm Harriet Watson, President of the City Club of Portland, and welcome to the last Friday forum for the summer, with its focus on the Oregon Health Plan. Please mark your calendars, however, for Friday, September 8th, when we will be back with a blockbuster kickoff to the fall and the election season. That will all be here at the MAC. There are still a few spaces left for the Fall After Work series, the Performing Arts Backstage. If you're interested, please call Suzanne at the club office or fill out and submit the coupon in the bulletin as soon as possible. Our board host today, seated at the head table, is Lloyd Anderson, immediate past president of the club and a member of the Board of Governors, as well as a local community icon. He will ask the first question of our speakers. Following Lloyd's question, we will open the program, as always, to questions from City Club members in the audience. Please line up behind the microphone even before Lloyd is finished so that we have time to ask as many questions as possible. Please identify yourself as a City Club member, and please ask your question in 30 seconds or less. We are very fortunate this afternoon to have with us such a distinguished panel of experts on the Oregon Health Plan to help us facilitate a thoughtful, informed consideration of current strategies, issues, and trade-offs relating to universal health care coverage. Dr. John Santa is the administrator for the Office of Oregon Health Plan Policy and Research, the office that advises the governor and legislature on health policy issues, particularly those related to the Oregon Health Plan. A graduate of Stanford University and Tufts Medical School, Dr. Santa did his residency in internal medicine at Portland's Good Samaritan Hospital. In 1992, after 13 years in solo and group practice, he became corporate medical director for Blue Cross Blue Shield of Oregon, a position he left in 1997 to become medical director of the Health First Medical Group. He has worked for the state of Oregon since December 1999. Dr. Santa has also just completed a 2-year term as president of the Cascade AIDS Project. Dr. Glenn Rodriguez is medical director of Health Services Integration and Quality Improvement for the Providence Health System in Portland. He also maintains an active family practice at Providence Southeast Family Medicine, a community-oriented health center in the Lentz neighborhood with a message to provide health care to the underserved. He is also an adjunct associate professor of family medicine at OHSU. Dr. Rodriguez has implemented quality improvement healthcare activities in numerous settings and various capacities, including as clinical director for the Navajo area of the Indian Health Service and as medical director for Pacificare of Oregon. His current interests focus on the applied use of electronic medical records and medical outcomes evaluation in primary care settings. Our third panelist, Philip Griffin, is project manager for human resources at Northwest Natural, the Portland headquartered natural gas distribution company serving Oregon and Southwest Washington. A graduate of George Fox University and Lynn Benton Community College, Mr. Griffin is a certified compensation professional and currently chairs the Oregon Coalition of Healthcare Purchasers. He is also active in many other boards and organizations, serving as vice chair of the Oregon Health Forum Board of Directors and board chairman of Northwest Medical Teams International. I am certain that his perspective on healthcare costs, employee coverage, and the role of business in setting state healthcare policy will be both dynamic and provocative. It is now my pleasure to turn the program over to our panelists.
Thanks, Harriet. Well, it's a pleasure to be here. There's copies of my comments on your tables, I believe. And I also brought along copies of an information packet regarding the Oregon Health Plan and Oregon's healthcare market that are on the table, and you might want to pick up if you're interested as you leave. Today is an appropriate time to share where the Oregon Health Plan has been and where it's going. Some of my most productive ruminations come in the warm and lazy days of August as I prepare for an always hectic fall. This fall will certainly be an important one as we debate so many issues. In its own unique way, Oregon will reflect on the past and move into the future. We've made enormous gains in healthcare in our state. We have an opportunity to consolidate those gains and move forward. Last month, during my I-5 commute, I listened to an NPR OPB presentation about the unique way in which a Brazilian city successfully dealt with transportation and environmental issues. Over a several year period, this city implemented unique approaches to public transportation and protection of the environment that succeeded despite modest resources. The city's citizens changed the way in which they lived and moved about. They supported leadership that was oriented to vision and solution and trusted that all involved could solve the inevitable new problems that they knew would arise as they ventured into new territory. Their solutions were unusual, refreshing, and inspiring. I think that their situation is similar in many ways to the successes we've had in the Oregon Health Plan. Sustaining our past successes will require more of the same. I want to share some of those successes and the challenges they provide to us for the future. We'll need to renew our commitment to those same principles: a willingness to change the way we live, support for leadership that offers solution, a trust in each other, and an ability to adapt our problem solving to current circumstances. There's unequivocal evidence that a lack of access to health care coverage results in health outcomes that are harmful. The American College of Physicians has made available a review of several hundred publications studying the medical effects of uninsurance. Uninsurance is a very bad disease to have. For example, an uninsured child is much more likely to go to sleep tonight with a toothache or a sore ear, or of more concern, develop abdominal pain tomorrow, wait and hope for improvement, only to find 2 days from now that their appendix has perforated. In contrast, a child on the Oregon Health Plan will more likely be seen, diagnosed, and treated prior to perforation. An uninsured woman today is likely convincing herself that the little thickness in her breast is of no concern and that she can delay mammography. Uninsured women are 50% more likely to be diagnosed with breast cancer at a late and fatal stage. Uninsured men are twice as likely to be diagnosed with late-stage prostate cancer. This data shows the degree that uninsurance reinforces the most dangerous of barriers to health care: denial. No one wants to believe their body's betraying them, even when the symptoms disease produces says otherwise. Denial is more easily rationalized when financial barriers are present. Oregonians can congratulate themselves for progress made over the last decade in solving many problems for hundreds of thousands of uninsured Oregonians. You've done the tough work, providing the resources, both public and private. Oregon's uninsured rates have been cut in half during the decade. We continue to make progress. The rate of uninsurance in Oregon went from 11% in 1998 to 10% in 1999, reflecting an expansion of health insurance to 30,000 adults and children. It's important to realize that these gains were accomplished through a public and private effort. Likely 2/3 of our success in providing health insurance can be credited to private industry, a robust economy, a competitive labor marketplace, and many private industry leaders who understand the direct and indirect costs of uninsurance. It's also important to recognize that insuring people in Oregon has been easier than in other states because of the relatively low cost of health care here. Oregon's premiums are lower than those in 90% of states. The cost to Oregon taxpayers of the Medicaid portion of the Oregon Health Plan on a per taxpayer basis is lower than in 70% of other states. Oregon's very moderate costs are now rising as a result of an aging population and a universal expectation that technologies such as new drugs, devices, and diagnostic tests be used to predict and improve our futures. Ironically, Oregon's frugal cost history continues to result in reduced Medicare funding compared to other states. When Medicare funding does not keep up with our needs and expectations, more pressure is applied to private insurance and the Oregon Health Plan. Cost issues will determine our choices unless we control costs. These have never been easy decisions. They won't be this time. Difficult decisions are at the heart of the progress we've made. What our data show is that the major beneficiaries of our work have been the very poor and middle-income Oregonians. We have been able to reach consensus around assistance to the disabled, the poor, and to children. Our robust economy and relatively low insurance premiums have helped more middle-income Oregonians become insured. Uninsurance in low-income Oregonians. These are people who are in families with yearly incomes between $17,000 and $30,000, individuals with incomes between $9,000 and $16,000, has actually increased. To succeed in reducing financial barriers to health care for these Oregonians, even more cooperation and understanding will be required than we've been able to muster in the past. To meet this challenge, we must understand several dynamic processes: poverty, the voluntary nature of our health coverage systems, and the barriers each of us have when it comes to helping ourselves and helping others. We must especially appreciate that one way or another, we collectively pay for health care for all. Poverty is a very dynamic phenomenon. From 1994 to 1999, 3.7 million individuals were residents of Oregon at one time or another. During the same period, 1,060,000 individuals received benefits through the Medicaid program, 28% of Oregonians during that 5-year period. While no more than 400,000 people were ever assisted at one time, a far larger number are assisted at some time. We know that a large number of individuals receive support for only 6 months, never returning to Medicaid. Factors affecting income are well known: age, level of education, race, and location. Geography plays a significant role in earning potential and uninsurance rates. For example, Washington County has a very low rate of uninsurance, 5%, while Coos County is at 18%. Per capita income is much lower in Coos and unemployment higher. The good news is that OHP dollars flow to the counties where they're needed in proportion to their needs. Wealthier counties basically subsidize poorer counties. However, for individuals, an eligibility cliff looms at 100% of the poverty level. I met a disabled truck driver in Albany who was grateful to the Oregon Health Plan for diagnosing and treating his Parkinson's disease, diabetes, and hypertension. I was very glad he wasn't out there driving a truck. He wondered, though, how he had come to lose his eligibility when his Social Security disability was approved. His disability income was a few dollars above the income eligibility level. He fell off that cliff. He's uninsured today. Ironically, in some settings, free or very low-cost coverage may not be a good enough price. Thousands of Oregonians are eligible for the Oregon Health Plan but remain outside coverage. Lack of information reduces awareness of resources. Modest cost sharing can be a significant obstacle. Information barriers may be language or culture driven. Despite some of the evidence I mentioned earlier of its importance, some of us prioritize access to health care low on our to-do list. Oregonians believe strongly in choice, both for individuals and for communities. We also believe in fairness. We need to ask ourselves whether it is fair that as a community we do not extend our help when the benefits of doing so seem clear. We also need to ask whether it is fair to our community when individuals with resources within their grasp do not stretch to obtain them. There are 130,000 Oregonians with above average incomes who are uninsured. We all have a lot at stake here. One way or another, we're responsible for health care for all. Making that explicit would seem to be a reasonable notion. The question and challenge is whether we have the resource and insight to make more progress. For low-income Oregonians, a combination of employer, government, and individual resources could be organized and incented to reverse the growing uninsurance rate for low-income Oregonians. That cliff could become a hill. The challenge would be for those resources to work together. Government, especially the federal government, will need to be more flexible. Business will need to be more creative and innovative. Uninsured low-income individuals will need to become better informed and participate in the healthcare purchasing process. Individual Oregonians will need to invest in each other through information, support for innovation, and an insistence on responsibility throughout the healthcare system. 15 years ago, we set out on this course. We've elected leaders who are problem solvers. They've brought us halfway. The rest is up to us.
Good afternoon. My name's Glenn Rodriguez, I was introduced earlier, and today I'll be speaking to you from my perspective as a practicing family doc. And I have the easy job. These guys have to give statistics and thoughtful analysis. I'm just going to tell you some stories. I want to put some faces on the folks who receive care under the Oregon Health Plan and reflect a little bit on some of the providers who provide it. There's also another dimension. Besides taking care of people as individuals, we do have a responsibility to try to understand the healthcare needs of these folks and the patterns of those needs and wants. And that's what I'm going to try to touch on here. First, I have a question for you. How many of you can think of right now, someone you know, someone in your life, who receives services under the Oregon Health Plan? Just raise your hand. Look around, probably half the audience is raising your hand. Well, I would challenge you, because if you really knew, you all know people who get care under the Oregon Health Plan. It may be a friend or a friend of a friend. It may be the landscaper who helps in your yard. It might be the elderly neighbor that needed nursing home or foster home care. John's statistic that 28%, so 1 out of 4 Oregonians over a 4-year period, 5-year period, were touched by the Oregon Health Plan. I find that really pretty amazing. But let me just tell you some of these stories. To try to put faces on it, I just went back and pulled my schedule from last week, actually the last 2 weeks, and just went through and went through the names there. And it was sort of an interesting process because I realized going through, I didn't know who was on the Oregon Health Plan for many of them, so I had to go look it up to see who was or wasn't, which was an interesting observation in and of itself. One family that I was seeing in follow-up, I'd first seen, and I've changed all the names, that I'll call Vladi, and he was a 15-month-old when I very first saw him a couple years ago. He's the 4th son in a Russian immigrant family. They didn't speak English. The father was on disability at the time. He'd been in an industrial accident. Devout Christian family, very suspicious of U.S. institutions, including healthcare, very suspicious of immunizations, really brought the child in for the first time at 15 months of age. The child couldn't crawl, could not sit, was very, very weak, low muscle tone. But we were able to get a multidisciplinary evaluation for the child and really identify this child had severe global developmental delay and really needed speech therapy, physical therapy. The family really needed help and structure in the home to understand and get the child in the early intervention programs. Child still has severe developmental delay, but has gotten advantage of many of those things that help the child adapt and grow as normally as possible. Another patient we first saw in our office when he was 19, and he was a Burger King employee. He was an earnest young man. He had a learning disability. Education was hard for him. But he was really intent on moving up the ladder and becoming I don't know, whatever you are at a Burger King shift supervisor or whatever, when he really began to struggle over the couple months before he came in. Now, he was responsible enough about things that he actually put off seeking medical care until he'd gotten qualified and enrolled in the Oregon Health Plan, and then he came in. And it, not a surprise that his about 4-month history of weakness and thirst and frequent urination and weight loss turned out to be onset diabetes and type 1 insulin diabetes in a young man. He was able to get access not only to the life-sustaining medicines of insulin and home glucose monitors, but really diabetes education classes, the things he needed to have to reorient his life, to really take care of himself and look forward to the future. Another gentleman I saw is a 36-year-old. He was 15 years status post to auto accident, left him with a severe head injury. He was left with balance problems and a seizure disorder. And I first saw him on referral from the emergency room because he'd gone there after a seizure, gotten a big workup, a CT scan. Well, it really turned out in the end, if you ask him and talk to him, the reason he had a seizure was that he'd run out of his medications and had stopped them. He'd really had no regular source of care for 5 years. And in reestablishing a medication program to control his seizures, he was really able to cope and function much better. And the great thing when I saw him last Friday, I hadn't seen him for a while, and then when I went back and looked this up in the registration system, he was actually covered by commercial health insurance now because his wife, he was doing so much better. His wife had gone back to work, had a full-time job, had commercial insurance, and he was playing the role of full-time caretaker for their young son and really, really doing well. It was quite gratifying. You know, one of the groups sometimes I don't think we think about, but we provide, as a society, extensive coverage to folks when they become eligible for Medicare. But there's no magic that says at 65 is when those health care needs start. And so it made me think about Jane, who, a 60-year-old, supporting herself and living independently, working as a maid in the travel lodge across the street from our office. She also had no health insurance and had put off seeking care until she got coverage. Quite worried about that, quite worried about paying her bills. And when she was seen, she really had dangerously high blood pressure. It wasn't complicated to evaluate an underlying condition and control her blood pressure, but at the same time, I noticed a growth on her nose that I was able to excise in the office, and turned out to be an early-stage basal cell carcinoma. Not a major condition, but one that, because we caught it early and took it off, was not a problem that it could have been later. And finally, I'd mentioned to you Peggy, who's really a delightful, crusty 82-year-old. She's been through 4 hip replacement surgeries. She has a number of other health problems, not unrelated to her lifelong history of smoking that she struggles still to quit, of heart problems and osteoporosis. And when she broke or had a loosening of the 4th hip replacement and chronic pain, and we went through the discussions about options, she really decided 4 surgeries was enough, and she was going to cope with it as it was. But to be able to stay in her home, the Oregon Health Plan really has provided the additional resources to cover her medications, so home care support, caregiver support, home safety evaluation, and other services that have really been the difference in allowing her to stay in her home. Now, one of her worries, interestingly, that came up a couple months ago was her son. She's 82 and her son's 49, but she still gets to worry about him. So she cajoled him into coming in to see me. And he had just, it was one, you walked in the room and it was just striking. He had a blistering skin disease on all his sun-exposed areas, which turned out to be a metabolic condition called porphyria, and he knew he had that, and he knew about some of the issues. But in really doing a thorough evaluation, we uncovered significant other health problems of hepatitis C, a chronic liver infection, and probably most importantly and most relevant, really, chronic alcoholism. That his other medical conditions, unfortunately, we won't be able to help very much until we really help him deal with that alcoholism. But as part of the intervention, our office care manager, we saw him as an uninsured patient, but our office care manager is getting him signed up for the Oregon Health Plan and eligibility for chemical dependency treatment and services. So I tell these stories. These are real stories. These are people that I've had the privilege to work with and take care of. And I tell these stories because, again, I want to make the point you all know people who benefit from the Oregon Health Plan. It's not them, it's us, and it's all of us. Now, what about the caregivers under the Oregon Health Plan? Well, I think the Oregon Health Plan represents an imperfect outcome of a decade plus of a good leadership in this state, a political coalition, and work to really try to address these problems. But one of the things that I'm not sure we fully appreciate, or many people fully appreciate, is the transition in the mid-90s, the implementation of the Oregon Health Plan opened the doors of many physicians' offices, hospitals, physical therapists, opened doors that had been closed for a long time to people who received services under a Medicaid program. And that expanded access, I think, had many impacts. And I can't prove this, but if you look at the original satisfaction surveys, the state every 2 years, I believe, John, does satisfaction surveys for people who receive care under the Oregon Health Plan. And in a baseline survey in 1994, before implementation of the Oregon Health Plan, and then in 96 after it, it was just striking to look at some of the shifts in overall patient satisfaction, including the percent that said they rated their overall care as excellent, the highest rating category, moving from, or excuse me, very good and excellent, the top two categories, moving from 46% to 56%. And those saying they had a provider that really listened to them. Now you think about that, your own healthcare providers. I'll let you all in the room rate that in your head. 90% of them in 1976 said they had a provider that listened to them. That just blew my mind. Furthermore, 94% of them said they knew who their primary care physician was, and 81% said they'd seen him in the last 6 months. I find that quite remarkable statistics, and really speaking to a degree of connection that I would argue was more difficult to provide previously. Now finally, from my view as a practitioner of taking care of people, again, I've told you individual stories and taking care of people one at a time. We also have an obligation I have an obligation to the whole group of people that I take care of, and trying to understand and make sure that I'm meeting the spectrum of healthcare needs that they have. David Lansky and the Foundation for Accountability has come up with a simple framework for describing healthcare needs, and I think it's really good. Think about it, see if it meets what you think you want from healthcare. But they talk about the basics, which are really respect, compassion, and trust. Help staying healthy, help getting better when you're sick, help living well with chronic illness, and help during the life's most difficult transitions, end-of-life care or serious disability. I really think that some of that statistics we saw in the satisfaction survey had to do with a perception on those who got their care through the Oregon Health Plan. The increased access really also translated into their feeling increased respect. I said I didn't know who was on the Oregon Health Plan or not. Oops, I can't find my health plan card here. I was going to pull it out. But when people come into my office with their health plan card, it looks just like any other health plan card. And finally, one thing that has happened under the ability to look at groups of patients, I work within the Providence Health System, and we do have, for both our Medicare and our Oregon Health Plan enrollees, we have health risk assessment forms that we send out to them. And surprisingly to me at least, 70% of the Medicare enrollees return them, and 40% of the Oregon Health Plan enrollees return them. It both helps us find individual that need help, but also look at patterns of care and patterns of healthcare needs. So for instance, the two most common self-reported conditions in the group of the Oregon Health Plan, think in your mind. Any guesses? What are the two most common self-reported medical conditions? Depression is number one. Very good. I think the Care Oregon table nailed that one. Actually, they're both mental health diagnoses. Depression and anxiety are the top two. And the first medical condition is actually fifth on the list, and that was asthma in our survey. And we also know more about preventive care patterns. It's good. I was just showing Phil before this that in Providence, we know our rates on many preventive care measures, both for commercial health plan members, Medicare health members and Oregon Health Plan members. So we know, for instance, that we've been successful in cutting our overall smoking rate in our commercial health plan from 20% to 15% over 5 years. But during that same time, our Oregon Health Plan smoking rate has not budged and has stayed at 38%. 38% smokers in Oregon Health Plan population. So we've had some effective interventions, but we've been less effective at reaching that group. However, in other areas, 72% of our Oregon Health Plan enrollees and 77% have received mammograms, 77% women's health care and pap smear, and over 5 years, the gap between the commercial and the Oregon Health Plan populations has really narrowed. So now it's for pap smears, it's just 1% gap. So at public health as a group, there's been real progress as well. So I just share my personal experience, and as I have experienced the Oregon Health Plan, as my patients have experienced the Oregon Health Plan, I think it's represented good care, I think it's represented good value, and I think it's helped express our commitment as a state to each other and strengthens the social fabric of our community that holds us together. Thank you.
Did you ever notice how doctors are always in control, no matter what kind of setting you're in? I'm batting cleanup. The total panel was given, I think, 30 minutes to make the presentation. The two docs here have used 28, so I think I've been diagnosed and I've had my prescription, okay? The diagnosis is you have 2 minutes, you know, take 2 minutes, go to bed, call us in the morning. So we'll see how quickly I can get through my piece. I'd really like to thank the club for the invitation today to talk about what I believe is Oregon's business's view of the Oregon Health Plan and the plan's value to Oregon business, how it's impacted health care costs and employee coverage, and the role of business in state health policy. I was asked because of the perception that the Oregon Coalition of Healthcare Purchasers represents Oregon business in the area of healthcare service. So, do we? Well, to give you a little background on the coalition itself, we have to date, after being in service for a little over 2 years, about 35 business members. Some of those you would recognize. The larger ones are like Tektronix, PGE, Northwest Natural, ESCO, Portland, Multnomah, PEB, which is the Public Employees Group. About 400,000 covered lives. And when you take a look at the number of covered lives, then that does represent an awful lot of coverage by a various group of health plans in the state of Oregon. So I think from that perspective, we can say that we do represent Oregon business in purchasing health care. What's the value of the Oregon Health Plan to business? I'm going to cover this question from the perspective of concern about the cost of health care benefits to employers. Escalating costs and health care quality are the primary reasons that the coalition was organized a little more than 2 years ago. Health care coverage for employers is a primary component of a competitive benefit package or a competitive compensation package, and I know all of you are aware of that in here. Depending upon the size and the type of your business, the National Business Bureau and the Chamber of Commerce says that you'll probably spend as a business between 7% and 15% of your entire payroll on benefits, on health care benefits. And if you're pretty labor intensive as a business, that could be that percentage of your total operating costs. The track record for health care costs shows that they're always above the CPI, nearly always above the CPI. So if the CPI is going up 4%, in a good year, your health care costs might go up 6%. Right now, we're into double-digit stuff with health care costs, and that gets a little bit concerning. We were in the late 80s, and actually when that happened, it spiked the uninsured rate. It gave the Clinton administration a platform to try for major health reform. It incented many employers into cafeteria plans with some type of a core defined benefit or contribution, and it ushered in the HMO era. And that really helped. For a period of time, that helped. Through the, I'd say from 1992-93 right up until about 1997 and into 98, healthcare inflation was somewhat near the CPI for the rest of the nation. Put this into perspective. Northwest Natural Gas Company spends about $9.3 million a year on health care benefits. We have an operating expense of about $79 million a year. So you can see we kind of fit into that category that's been reported. Our health care costs rose 4% in 97, 7% in 98, 15% in 99, and so far it looks, well, 14% for renewals in 2000. And we do have a cafeteria plan, and people do get a choice in the benefit that they belong to, and we have a fairly good-sized group. And I know how this has affected some of the smaller businesses. They've been looking at 25 to 35% increases in their health benefits. So that's alarming, and we need to help do something about that. Health plans in Oregon, and we know this because the coalition works quite closely with the health plans in finding out what's going on and how we can do collaborative efforts to control things. They're predicting double-digit increases in their commercial contracts for the next 3 to 5 years. So if you're in business, you need to brace for that. That brings me to the question of the day: why should an employer group of healthcare purchasers faced with substantial increases in health benefit costs for their own employees support a plan that covers low-income residents who aren't their employees? And let's set aside for a minute the moral obligation, because I think there is a big one, and let's just talk about the cost issues. And so picture a pie, and this is an announcement of your dessert, but just picture a pie. Now, if you take a look at that pie, it's going to be cut into a number of different slices. One of them is prescriptions. And all of us know about pharmaceutical costs, I think, and what they've done to healthcare benefit costs in the last couple of years. Inpatient service, outpatient service, laboratory and diagnostic service, administration, and then one slice named uninsured. Okay? Costs passed on from the health services industry because some of their clients are uninsured, and that slice of pie goes directly to commercial and individual contracts, those of us that pay out-of-pocket money for our health care coverage. That's about 12%. If you looked at that pie again, that's about 12% of that pie. Now, to put that into perspective, for Northwest Natural, that's about $1 million of the $9 million. That's a big piece. If your business is in Oregon, or primarily in Oregon, that slice would be about half as large as it is in 42 other states. And that's because, and not to us, Northwest Natural, that means the savings of about $500,000 a year. That's because of the Oregon Health Plan. So there really has been a tremendous benefit to businesses in Oregon because of that. It's been a terrific reduction in the cost shifting. That's been through emergency room visits, which have declined as much as 10%, and this is all information that I got directly from Dr. Santa, but I believe it. Depending on which report you read, charity care at hospitals has declined from 20 to 30%, and that includes a big load of bad debt. High-risk individuals formerly turned down in the commercial market have received coverage in a high-risk pool. That's made it easier for employers to insure their employee force. Provisions that guarantee issue and limit rate variation, which were also part of the Oregon Health Plan initiative, have enabled small employers to provide their employees coverage. Workplace-based insurance in Oregon has grown from 60% of the insured population to 70% during this period of time. So it wasn't a situation where business shoved it back on to the health plan. It was actually a situation where, because of some of the other things that the health plan did, businesses were able to insure their employees. The cost of the uninsured health care is shifted directly to commercial and individual insurance purchasers. Most of us in here today are in that situation, and it's cut that slice, that portion of the pie, in half. And that's significant, and it hasn't happened, like I said, in 42 other states. So we are unique in a lot of the things that we do, and I'm really proud of what that's done for us as employers. Any significant reduction, obviously, in the Oregon Health Plan and Medicaid is going to shift back and cause increases in the private sector. Oregon business communities pay for health in 3 or 4 ways, actually, when it buys health group insurance for their employees, in state corporate taxes that fund the general budget, part of which, about 20%, I believe, goes to human services, which also then is a part of that's delegated to the Oregon Health Plan. Employers need to know that the dollars that go to the health plan are matched 2 for 1 by Medicare or Medicaid. And that's a good deal. When you can get that kind of match, that's a good investment. The portion of the medical premium, again, that represents health care services is the shifting of charity and the bad debt and the underemployment. So that piece that gets shifted back would be underpayment. I'm sorry, I didn't mean underemployment, I mean underpayment. I'll talk about that in just a little bit. So I hope that gives you a sense of what I believe purchasers or businesses feel are the benefits of the Oregon Health Plan. The role of business in health care policy. I want to talk about the role that business should play in the health policy, and I want to use it broader than just Oregon, the Oregon legislature or Oregon bills. I don't want to limit it to that. And just let me revisit for a minute some of the CPI increases as compared, I'm talking medical CPI as compared to the regular CPI. 3 to 4%, we've seen a real good cover or lid or control on inflation costs overall in the last few years. Medical, it's been 10 to 20. And the reasons given by the plans and the providers, utilization increases, more medical technology, prescription increases, competitive salary for doctors, Medicare and Medicaid cost shifting, and overregulation. The reasons that purchasers really need to take a closer look at are preventable medical errors, absence of standardized information systems, variation in treatment practices, lack of clinical outcome data to support purchaser decisions, inequitable method of Medicare reimbursement. That's something that I think all of us can really get hot about if we understand the implications there. And then overregulation. So what can purchasers do? What can the businesses do? You can create a purchasers' public policy committee that brings a united voice to the legislature on both state and federal issues. Currently, our coalition has such a committee, and we've been working. And I left a booklet or a little pamphlet there in the middle of the table so you could try and, if you get a chance and you're interested, you can look through some of the information in that. I have to say I cheated too. I put a Northwest Natural Gas Company appliance brochure in there. So I don't get fined for that, I don't think, at this club, but it's got a $25 discount coupon in there with it. So what can we do? Well, I want to tell you a little bit about what this committee has done so far for Oregon businesses, and I'm talking about the political or the policy committee. And recently, I think this has been in the news, it's died down a little bit, but that's the Patients' Bill of Rights, or the Patients' Protection Act at the federal level. Their version, and it got passed through the House. The House version of the bill left in question the potential of employers to sue employees to sue their employer if the employee's employer provided medical plan caused them damage. Think about that. I mean, if you're in charge of a company that provides a medical benefit, just think about the implications of being liable if something goes wrong with the treatment of your health plan, or that your health plan gave your employee. Employers as a group had to remind Congress, and we did write letters, that employer-provided medical benefits are not required, and that there are already 45 million uninsured people in the United States. And it just blows me away that there's not that connection at our legislature, that if you really mess with that, you will scare employers away. They already are in a lot of litigation over a lot of different things. And that would be a death blow to employer-based medical coverage. I'm not saying that we would all just cut and run and employees would be on their own. Probably go to some kind of a defined contribution and say, here's your $300, go find your insurance plan, and just completely back away from it. So I'm not sure there was a lot of good in-depth analysis of that, but at least it's stalled in the Senate, so it probably won't happen. The Public Policy Committee is currently representing purchasers in a task force the governor formed to bring patients advocates, the AFL-CIO, and health insurance plans to consensus agreement on issues that were going to be presented on 8 different ballot issues. 8 different ballot issues. These, again, were all around patients' rights. That's not going to happen because the coalition and actually the governor stepped in and said he'd like to get this group together to talk about it and see if we could come to some collaborative decision. So there really is a good spot for employers to gather together and have a voice in the way that health plans are treated as far as regulation is concerned. And overregulation costs us all a lot more than it benefits. Healthcare quality, and I want to close with this. purchasers can create a form that brings plans and providers together with the purpose of improving quality of care. In every industry, and follow me here because I know a lot of you have had businesses or have businesses currently, but in every industry, the benchmarking and the standardizing of best practices and reducing variation has dramatically narrowed error margins and driven down costs. And if you think about it, those of you who are in manufacturing, the ISO 9000 quality efforts that you have to make in order just to sell your product, it has brought down costs. So standardization and best practices. And I'm sure that you've read and heard the recent article that came out. Institute of Medicine reported that 40,000 to 90,000 people die in hospitals each year as a result of medical errors. Well, those are the ones that are reported. So there's a long way to go in best practices and standardization. Purchasers should require the same kind of evidence of quality and performance in healthcare as we do in other products that we purchase. Now, you can have a little fun here. When was the last time that the benefits section of your HR department reviewed the diagnostic and treatment outcomes of patients served by the health services you contract with? When was the last time that was done? What's the mortality rate of the cardio bypass surgeries at the hospitals that your plan uses? Could you go find that for me this afternoon? When you get back to the office, tell your HR director you want to see those statistics on the health plans that you use. Put this in perspective. Call your purchasing manager and ask to see the spec sheets on the quality guarantees in the contract you have with your major parts or equipment supplier. He'd probably be there in 5 minutes. I think it's up to businesses and the medical community as well to begin to define clinical outcomes, to publish that information, to share it. A lot of them do it on their own. I'm not saying that doctors are blind to this kind of thing. A lot of doctors, a lot of plans do this on their own. And they do good work, but it's not shared. And so the coalition has created a nonprofit organization to bring all of those affiliates together, to begin to try and develop a plan, to bring that information to the table, norm it so it takes care of the differences in the kind of patients that are treated, and begin to publish it so we can create best practices and we can drive down costs. We need to do that together. Purchasers can't do that on their own. It takes the full medical service community as well as purchasers, as well as the legislature, to get those kind of things to happen. I believe I've addressed, I think, what I was asked to, and again, I appreciate the opportunity, and that is to present what I think Oregon business views the Oregon Health Plan in. Thank you.
Phil, you didn't say whether that $25 coupon would go for my copay when I get to see the doctor next time.
It's just gas appliances.
If the aim, this is to Dr. Santa, if the aim of the coverage for the health plan is to cover health for all Oregonians, what would it take to get that done? And particularly, you've got this hospital initiative now being, I think it will be before the voters, which will limit the tobacco settlement to health care issues. So what will it take to get that done?
If you look at the current population who are uninsured, I think we have somewhere between 60 and 80,000 people who qualify for the Oregon Health Plan and have not come forward. Since those people, there's substantial costs in insuring them, there's probably a couple $100 million there if they all came forward and all enrolled. There's 130,000 people, as I mentioned, whose incomes are above the income of the average Oregonian. Getting them to come into the market and provide their own resources, I mean, they're overwhelmingly employed. They have resources, but obviously that's a substantial amount. Then the group I tried to focus on and we're most interested in is low income, uninsured, And the complex thing about that group of people is I think there are and they deserve to have 4 parties, all of whom have resources, sit down and try and figure out how to get it done. But that means it's going to be really difficult. The 4 parties are individuals. Those low-income folks don't have a lot of resources, but they have some. The state, the federal government, and business. Those individuals are overwhelmingly employed. There's state resources, there's federal resources, but government is very worried about providing any resources in fear that business will retreat in terms of the resources that they've provided. It's called crowd out. But there's substantial resources required there from all 4 of those parties. The current initiative, there's 2 of them, one from the legislature and one from the Hospital Association, would generate, I think, something around $30 to $40 million for the plan. Given all the cost issues that are out there, that would help. Don't get me wrong. It would really help to stabilize the current plan. But frankly, we need more than that to do any expansion.
I'm Dr. Ewan Horniman. I'm a member of the City Club, and I'm on the Health Issues Committee. Like every other health plan which is dependent on taxation, the Oregon Health Plan is underfunded, and in Oregon, doctors are withdrawing their support. And in addition, the Oregon Health Plan has a managed care format, and the doctors in Oregon are withdrawing their support for managed care. This question is directed to Dr. John Santa. What contingency plans do you have to protect the Oregon Health Plan if Bill Sizemore's taxation reform initiative passes in November?
Well, there's a number of options. None of them are pleasant options. I think those options range from large numbers of individuals losing eligibility on the plan. Those options include not continuing the current waiver we have with the federal government. And that would affect the benefit plan for those individuals who are now covered. There's a variety of other options. They're not pleasant ones.
You haven't answered my question. What is the contingency plans to protect, not to destroy the Oregon Health Plan? I'm a supporter of the Oregon Health Plan. There has to be an alternative plan to protect it.
Well, Dr. Horniman, I think Mr. Sizemore's initiatives, given that they're ballots, and that would be an indication of the voters' sense, I think raising revenues in to cover the losses from the Sizemore plan. I mean, I'm really not the expert at political issues, but I think that'd be very difficult. I think we would try and do the best we could to allocate the resources we have to as many people. But I think a scenario in which we'd be able to do so in a way that everybody who's on the Oregon Health Plan now would get everything they're getting now is very difficult to imagine.
My name is Jerry Keene, member of the club. My exposure to health policy is just mainly on the workers' comp side, which is kind of a weird one off to the side of most of these issues. But I seem to remember 10 years ago or more when the Oregon Health Plan was being developed, and at that same time workers' comp reforms were going on, and there was some kind of bargain struck at the legislature where, as a component of the workers' comp reforms and the Oregon Health Plan, there was going to be a third leg of it that involved obtaining an ERISA waiver so that there would be a small business mandate in Oregon to actually pay for some uninsured low-income folks to participate. I think it was in the Oregon Health Plan, and it was called an employer mandate. And that word, kind of struck terror in some people, but it was actually passed, I thought, into legislation. And then that aspect of it kind of withered on the vine. And I'm just curious, one, what happened, because I couldn't tell. And two, to what extent would reviving that concept help solve some of the problems you've identified today?
Historically, the Oregon Health Plan legislation did include an employer mandate. The problem was that required that a federal law called ERISA be changed in order to facilitate that. There was a federal law in conflict with that. The state was unable to get the federal government to change the ERISA law, and so essentially the employer mandate sunsetted. I would remind everyone, though, that, I mean, I've gone back and read some of the historical documents out about that thinking, realized that though there was a mandate on employers to offer insurance, the decision to require employees to buy it and to pay their portion was not going to be mandated. So individuals would have still had to decide that health insurance was worth it. And you should be aware that a major, if not majority component of the problem in employer-based insurance is employees who are offered insurance but can't afford it or decide not to buy it. In terms of the status of employer mandate strategies now, I think those would be difficult. We've tried to look instead at if we could mobilize federal money, if we could get the federal government to be less afraid of engaging with business, and through one strategy or another, tax credits, matching funds to states, allow us to engage business with the right kinds of restrictions, we think we could make some progress. But that's difficult. It would take everybody, those four players, all agreeing to do something.
Matteo Lucio, City Club member, and I'm a research analyst for Multnomah County's Behavioral Health Division, Managed Care Programs Unit. And we have a contract with the state's Mental Health and Developmental Disability Services Division to run, to provide mental health services under the Oregon Health Plan in Multnomah County. And the head of that state agency, Barry Cast, in a recent memo, hinted to major reexamination of the Oregon Health Plan by the governor and the legislature as soon as the legislature reconvenes. And so aside from the question of, the threat of budget cuts if Sizemore's initiatives pass, what do you think, and this is addressed to anybody on the panel, what do you think some of the major dividing lines and issues in the legislature are going to be regarding the Oregon Health Plan?
Well, I think as I talk to legislators, a major issue is going to be cost, and how we're going to deal with cost issues on the public side. And one of their major concerns is realize another leg of the Oregon Health Plan was that it would, at least in part, try and control costs through benefits. We would be able to alter our benefit design. And the federal government has also stopped us from doing that. And I think the legislature will be asking to what degree is that still viable, and as a result, to what degree can we control costs. And we're certainly, not surprisingly, given this governor and the environment here in Oregon, looking again at benefit design issues. But those are tough issues. I think they're going to obviously look and be interested in revenue issues. And what's unusual about this fall is there's a wide spectrum of possibilities. Let me give you an example. If the federal government passes coverage for prescription drugs for seniors, depending on the bill that's passed, that could free up $30 to $40 million of state funds, because the most costly seniors are in Medicaid, where we cover 100% of their prescription drugs. And if the federal government said, we'll do that, we have $30 to $40 million. If the hospital associations initiate